Dear Professor Mills, dear Professor Hahn, dear colleagues and friends, thank you for the introduction and thank you for having me on this really great meeting. It's an honor and my pleasure to present to you today our work from Basel on the use of high-sensitivity cardiac troponin T and I for the early exclusion of functionally relevant coronary artery disease. Well, coronary artery disease continues to be a major cause of cardiovascular burden, and it is still accounting for a vast number of hospitalizations, millions of deaths, and excess healthcare costs worldwide. And its dynamic nature that may result in a variety of clinical presentations with different risks for future cardiovascular events. And given this, the early and safe exclusion of functionally relevant coronary artery disease is really a crucial but yet unmet clinical need. Because in current practice, risk stratification is mainly based on clinical assessment and exercise stress testing or cardiac imaging. And indeed, these methods may be beneficial in many patients, but however, they seem to be increasingly inappropriately used, and they are frequently associated with either modest predictive value or with restricted availability, radiation exposure, and additional costs. And it is in this context that, as you certainly know, biomarker-based strategies have gained increasing attention, and in particular, cardiac troponin seems to be attractive as it is becoming an increasingly sensitive biomarker and is already well established in the early rule-out of acute coronary syndromes. So we aim to derive and internally validate optimal cutoffs for different high-sensitivity cardiac troponin assays for the early and safe exclusion of functionally relevant coronary artery disease in patients without known coronary artery disease. And we aim to assess a prognostic value of high-sensitivity cardiac troponin when it comes to adverse cardiovascular outcomes. This analysis is part of the Basel 8 trial. Basel 8 is an ongoing and large single-center prospective diagnostic cohort study which actually was designed to advance the early detection of functionally relevant coronary artery disease. We enrolled patients with symptoms possibly related to FCAT who were referred to the University Hospital Basel between Jan 2010 and May 2016 for a rest and stress myocardial perfusion imaging. And after collection of all relevant clinical information, the patients received a blood draw for the measurement of high-sensitivity cardiac troponin concentrations before stress testing. 2 independent cardiologists who were blinded to those troponin measurements then adjudicated the presence of FCAT based on expert interpretation of the MPI SPECT-CT images and on coronary angiography whenever available. And after 5 years, we performed the follow-up to collect information about adverse cardiovascular events. We excluded in this analysis patients who had previously known coronary artery disease, patients with missing high-sensitivity cardiac troponin concentrations, and patients with renal failure on chronic dialysis. We used 2 different widely applied high-sensitivity cardiac troponin assays, namely the Roche Elexis high-sensitivity cardiac troponin T assay and the Abbott Architect high-sensitivity cardiac troponin I assay, for each of which we assessed the safety and efficacy of different cutoffs. And we predefined the sensitivity and negative predictive value, each of at least 90% as acceptable performance criteria. We used the bootstrapping procedure to assess in the next step the internal validity of the cutoffs for a realistic estimate in future similar patients, and we used a multivariable Cox regression model for the survival analysis. So 2,111 patients without previously known coronary artery disease were eligible, of whom 23.6% had a final adjudicated diagnosis of FCAT. The baseline characteristics in our cohort were similar to those of other cohorts of suspicion with FCAT, with a median age of 68 years and 44% being female. 71% had at least one cardiovascular risk factor, and 40.7% were already on aspirin, and 35.5% were taking statins. So for the Elexis high-sensitivity cardiac troponin T assay, the optimal cutoff that reached the predefined target for sensitivity, which is shown here as the blue line, and MPV, which is shown as the red line of 90%, was 5 nanogram per liter. And this cutoff actually reached a sensitivity of 90.8% and an MPV of 90.2%, triaging 468 patients, that is 22.2% directly towards rule out. For the high sensitivity cardiac troponin I assay from Abbott, we identified an optimal cutoff of 2 nanogram per liter, which reached a sensitivity of 91.6% and an MPV of 90%, triaging a similar number of 422 patients. That is, again, 1/5 of the patients directly towards rule out without the need of cardiac imaging. We obtained very similar results for both high sensitivity cardiac troponin assays in our bootstrap internal validation, which shows robustness of our findings when it comes to similar future patients. For the prognostic outcome, we constructed those response plots which model the adjusted continuous relationship between cardiac troponin and the outcome, which is here all-cause death, within 5 years of follow-up. Troponin was handled in a continuous manner, and in order to avoid imposing linearity, we used restricted cubic splines. We computed the hazard ratio with a multivariable Cox regression model, adjusting for age, sex, BMI, cardiovascular risk factors, as well as past medical history. And what you can see is that for both high sensitivity cardiac troponin T and high sensitivity cardiac troponin I, an increase of the cardiac troponin concentration is associated with an increase of the hazard ratio. However, this was significant for high sensitivity cardiac troponin T, whereas it was not for high sensitivity cardiac troponin I. And I think that's in line with yesterday's presentation of Luca Köchlin, who has shown that the prognostic accuracy of high sensitivity cardiac troponin T is higher for all-cause death than the one of high sensitivity cardiac troponin I, and he has shown this in an independent cohort to ours. We obtained similar results when it comes to the outcome of cardiovascular death. Limitations of our study are the single-center design, but MPI SPECT-CT was applied as the standard imaging method to patients with a wide range of pretest probabilities, so this may have counterbalanced a potential referral bias. And also, we really used a very stringent method to finally adjudicate the presence or absence of FCAT. We cannot exclude that we potentially misclassified a small number of patients. So to conclude, our analysis has shown that in symptomatic patients without previously known coronary artery disease, very low high sensitivity cardiac troponin concentrations, below 5 nanogram per liter for high sensitivity cardiac troponin T, and below 2 nanogram per liter for high sensitivity cardiac troponin I, may generally allow to safely exclude functionally relevant coronary artery disease in a relevant number of patients. And in addition, our results indicate that high sensitivity cardiac troponin concentrations above the derived cutoffs had a prognostic value as they were associated with substantially higher cumulative incidence of all-cause death and cardiovascular death within 5 years of follow-up. With that, I want to express my deep thanks to the fantastic research group of the Cardiovascular Research Institute in Basel, and to you as the audience for your attention, and I'm happy to take your questions.
Very nice presentation. Just while we're waiting for some questions, some thoughts. So we heard in the previous presentation that lipid markers can let you down. So it's great that we moved back to troponin, which never lets you down in terms of prediction. And not just one troponin, 2 troponins, just for safe measure. This is the biggest challenge, though, I think, for troponin, how to use it effectively in this setting. And I'm interested in how you arrived at the threshold of 90% negative predictive value as your target, and whether you had any discussion with patients or clinicians about how happy they would be being told that I can, with 90% confidence, say you don't need to go on and have a functional test, but 1 in 10 of the times I'll get that wrong. How did you derive that threshold, and do you think that clinicians and patients will accept that in practice?
So we actually, this is a very good comment, thank you. We actually decided on this predefined performance criteria based on previous literature, which has made similar studies also using those performance criteria. But it's a very good point, yeah. If you want, you can think about elevating this criteria.
Yeah, I think for the prediction of MACE, usually it's a combination of troponin as well as coronary risk factor, like age, diabetes, and all that, smoking. And do you use that model? Maybe you can get a better prediction if you combine troponin value as well as the coronary risk factor. Have you tried that model in your data?
Very good question, thank you, but we didn't look at this until now. Yeah.
One more point. So you focused on rule out, but patients who've possibly got important coronary disease often have higher values. Did you interrogate whether there was any role for using higher values to defer functional testing to go straight for invasive angiography, because there are a group of patients whom functional testing is probably not necessary, and you could go straight to definitive anatomical testing. Did you explore that at all in the data set?
Thank you again for this question, but no, we didn't until now.
Okay. It'd be interesting to see whether there's additional value beyond rule out in this setting. Okay, if there are no other questions from the floor, then we'll move on to the next presentation. Thank you for an excellent talk.